a sports medicine, family medicine doctor at Kaiser Permanente Medical Group in Roseville, California. He is originally from a small town in Central Valley of Lemoore, which is about 40 miles south of Fresno, where his parents owned a grocery store. He attended UC Davis for his undergrad degree, and he's also did his MPH at UC Davis, and that fueled his interest in primary care and preventative medicine. He moved to the Midwest for medical degree and postgraduate training at Des Moines University in Iowa, and then moved to Chicago for his residency at Ascension Resurrection, and then followed with a fellowship in sports medicine at the University of Chicago. He's interested in preventive medicine, nutrition, weight loss, chronic disease, uh, and all diagnostic ultrasound. And he also does apparently a lot of injections with ultrasounds and various chronic MSK injuries. Um, After being in the Midwest for 8 years, he finally came back to California in 2024, and now he's working at Kaiser Permanente in Roseville. He is happily married to Jasmine, who he met in Chicago in medical school, and he has a 2-year-old Doberman Pinscher. And he's also someone that I get to call a friend. So I'm honored to have him join us today.
Thanks, Juven. How's everybody going? Sorry, I can't see anybody.
You can't because you were using the Zoom webinar.
Oh, okay, got it. Yeah, so sorry, I had some technical difficulties. Kaiser has a pretty in-depth firewall in place where I can't basically access Zoom from multiple different modalities. But yeah, so I
They
mean,
don't they don't trust you with access to the computer.
I'm the older generation now. I could see why. I was like, man, I'm behind with the times. I'll soon be having issues with all sorts of technology. But yeah, I mean, thanks for the introduction, Jubin. And um, oh, this poll kind of came in here. Okay. Um, yeah, so kind of my beginnings. I grew up in a small town. My parents owned a grocery store, so I worked in groceries up until college or so. Again, very small town, maybe 20,000 where I grew up. My parents owned a grocery store, Riverdale. It's like 2,500 people or so. Very small, like farming town. So, I never knew anybody in healthcare, and nobody in my family was in medicine. So, I don't think I was interested. I didn't think that was realistically an option. I went to Davis for college, and I remember I majored in biology just because I liked biology in my senior year of high school, but I don't think I was by any means like swayed by it or that I would, make, I had no idea what I wanted to do with that. And I mean, throughout kind of college, um, I probably found medicine late, like probably the last quarter of senior year or fourth year. I took an anatomy class that I really liked. I thought I was like maybe interested in optometry at that time. I had like a lot of eye problems growing up, played sports. But I remember I went through like so many different contacts growing up. I always thought maybe that I'd want to do something with the eyes. Um, did some internships, actually took the standardized test, the OAT for optometry school, but I shadowed a couple optometrists and I was like, man, I just can't do this. And so, I mean, kind of fell into medicine on a whim. I think one of the optometry internships at Davis was taken up. And so it was all filled. And I was like, okay, I got to do something from an extracurricular standpoint. And so I just volunteered at UC Davis Medical Center and like I think the cardiology like step up unit or something. You're basically just filling up you're filling kind of towels, you're helping the nurses around, maybe feeding patients and things of that nature. First, basically that was the first experience I ever had in a hospital. And so I was literally had no idea how things ran. And so one experience kind of led to the next. I was like, yeah, I mean, let's kind of flesh this out more. And slowly and surely, it got me more interested in medicine. Worked as a scribe as well in the emergency room, which I thought was a great experience. That just, knowing more about just different aspects of medicine, the fast-paced nature of things. Um, Learning from the ER docs themselves. Very good experience. I think it's for any pre-med. I also worked as like a medical assistant for an ophthalmologist's office. Um, we also volunteered, and that's how I met Juven through the pre-med conference at Davis, which was huge. I remember that was one of the first ones when I went to. I think I went to the one in 2011, and that really inspired me to potentially make it as a doc. Richard Carmona was the doc. I remember he gave that talk, and he was so personal. He was the Surgeon General of the U.S. I think he's Puerto Rican, if I remember correctly, Puerto Rican family, and he was just telling his beginnings, which are extremely, from the ground up. I think he homeless? I can't remember exactly. I don't know, Juven, if you want to kind of jump in there, but I think he was a nurse. He was like a PA. He went to med school at UCSF, became a surgeon, and then Surgeon General. Yeah, really inspiring story, and I think that conference really kind of gave me confidence that maybe I could pursue this route. Um, and so one experience led to another. I took several gap years before med school actually even started, and I knew that would happen because I knew I found medicine pretty late in my career, in my undergrad career. So I knew I'd take at least maybe 2 or 3 gap years to really beef up my CV. And so I did my MPH in between as well. That was kind of not part of the plan either. That kind of came along the way. I think that, kind of um, reinforced some of the desires to I always thought I'd go into primary care. I always liked kind of treating the whole patient. Preventive medicine was a huge thing. Getting to know your patients. I really liked all those aspects of primary care. And so I always thought I would kind of go into that field. And when I finally went to med school, so I went to Des Moines for 2 years. Quite a different kind of experience. I think that was probably the best experience, or probably the best decision, is to kind of go out of state for me. I knew if I didn't leave California, I probably would never have left. So that was probably the best thing to do, is just to leave California, kind of get out of your bubble. I think that was a big thing. Getting out of my bubble, meeting totally different people, form a different family in a sense, in the Midwest, and kind of everyone's going for the same thing when you enter med school. It's hard, especially the first 2 years were very hard, I thought. I mean, I was never really like a book guy, and so I think it was kind of struggling the first 2 years. Um, I, the first 2 years essentially it's all preclinical, so it's just test after test after test. You're just studying like all day, like every single day. I mean, it was definitely tough. I don't know if I would do that again, honestly. It was really that I thought it was pretty tough. Once the clinical years came on, year 3 and 4, much better, because you could kind of see what you learn and how it applies to actual clinical practice. So I moved to the Chicago area for years 3 and 4 for my clinicals, and further strengthened my desire to go into primary care. And then after that, I matched in Chicago, my first choice. I wanted to stay in Chicago. Um, and residency right around the start of COVID. So different experience from that standpoint. Everyone wore masks inside the hospital. You had to be kind of doing a lot of your um, not like your lectures and things of that nature and residency. That had to be all virtual for the most part the first couple of years. So I felt like that was a very different experience. I feel like COVID's been a far cry at this point. Feels like it's so long ago. Now no one really wears masks anymore. I still do in clinic just for safety reasons, but um, yeah, I really enjoyed my time in Chicago. I really enjoyed residency, actually. Tough hours, you're on call, you're doing a lot of things that you don't really necessarily care for in terms of some of the rotations you're on. But altogether, a very solid experience, learned a lot. Again, I'm more of a clinical person, so I don't really like reading textbooks per se, or kind of just like studying for tests in general. I like to apply the knowledge that you learn into the clinical realm. And so anytime you see a patient in front of you and are expanding your differential, coming up with a treatment plan, to me it's much more, it sticks much more. And then in residency, I found out about MSK. I had no interest in, I had no idea about sports medicine really. I thought I would just be a general practitioner.
Dr.
And
Ng, can you tell them what MSK is? Because most of them probably don't know what it is.
oh, sorry, musculoskeletal. So like before residency, I had no idea what like sports medicine or what musculoskeletal really was. And I could probably tell you when I was in residency first, especially the first year and a half, probably, I'm sure my exam was terrible. Like I had no idea how to um, take a look at a knee or a shoulder or how to properly evaluate like joints and joint related pain. It's very nuanced, and once you get into it, it makes a whole lot of sense, though, which is great. It makes a lot of sense when you're actually doing it. The exam maneuvers you do make a whole lot of sense in what you're trying to stress in terms of what ligament, what bone, what piece of cartilage, whatever. So yeah, that kind of came on by accident as well, kind of my love for sports medicine. And so I decided to do a fellowship. So I stayed in Chicago, University of Chicago, for another year to do that fellowship. Probably the most fun. I feel the more you progress in your medical career, for me, it gets better because especially if you're really clinical, if you like the clinical aspect, I think, you're only learning and learning and learning. You continue to learn, every aspect you're going to learn quite a bit, in clinical rotations, you learn a ton for years 3 and 4. Residency, of course, every single year you learn a lot. And then fellowship, that year of fellowship was all musculoskeletal. And I learned a ton in that year. I mean, orthopedics is, as a field, is the residency. Orthopedics is 5 years, and primary care sports medicine is basically everything fit into 1 year that's non-surgical, along with all the ultrasound training you have to do. So it was pretty busy, but it was really fun. Covering schools, covering universities, um, and kind of balancing the clinical work as well. That whole year is trying to see as much as you can, because a lot of medicine is seeing by doing and repetition, repetition, repetition. And that's why a lot of the older docs, they've seen everything, and so there's really no substitute for experience. So I asked, I'm the new guy here at Kaiser. So after fellowship, me and my wife moved to California. So I went to Davis for college, so pretty close by, but I never really knew the Roseville area. So I really enjoy this area so far. I really enjoy the Kaiser model. Especially it really mirrors that of other countries, especially countries who are more, universal healthcare in terms of kind of one big model which controls a little bit of everything and really is really supports primary care and preventive care. And a lot of work falls on the primary care physicians for that reason. And so I think the PCPs here probably work, we work really hard. And a lot of my colleagues and partners work really hard. And the workers were very much rewarding, though. So, I'm about 6 months into my first job here. I really enjoy it. And I basically, for my split, I do. I'm basically the musculoskeletal guy in the group, and so I use a lot of ultrasound. I do a lot of injections, basically all injections, like shoulder injections, hip injections, knee injections, finger injections, foot, ankle, everything except the back, because those are more your physical medicine and rehab guys will do the back. So I do a lot of injections. I have dedicated time for just musculoskeletal, where I just take referrals from colleagues in my unit, but also in other units here as well. And I probably like a 70-30 mix, 70% primary care and about 30% musculoskeletal in my practice. Probably growing in terms of the musculoskeletal as I'm kind of breaking in, getting, my partners are getting to know me more and sending me more stuff. And so ultimately, my goal is maybe like a 50-50 split so I could retain a lot of my primary care, but also my passion for musculoskeletal. So that's basically my story.
So I think so you guys put your questions in the Q&A and we'll ask Dr. Au-Yeung. I would say the one question I wanted to ask, what, so basically tell us what your day is. Like you wake up and just tell us like what your average day is working as a sports medicine.
Yeah, so average day, so you probably heard primary care is a lot of inbox. So you have a lot of messages, you have a lot of phone calls throughout the day that you're kind
So
of
like
working.
it's what time do you wake up and then just go chronologically down.
Okay. So I usually wake up around 6:15 a.m. or so. Sometimes I'll wake up at 5 if I'm going to do a workout in the morning. So me and my wife have a dog, so I usually wake her up in the morning and we go for a little bit of a walk. Um, Come back and make her breakfast. By that time, I leave for work, brush my teeth, of course, and all that stuff. Get ready. Go to work around 7:30. Get there around maybe 8:15 or so. My first patient is not till 9, and so the first like 40 minutes or so is all inbox. And so from the night before, you see all the stuff, patients that message you overnight and into the morning. Some kind of requests. Just like notes from specialists, from patients, and results from like labs and imaging that you ordered the day or days previously that just came in. So address them, call patients if you need to have a kind of follow-up appointment or just plan in general. And then from 9 to really 12:30 or so, I see my morning schedule of patients. Again, depending on the day, it's mostly MS. It's mostly my primary care patients. So you see a lot of physicals. You see like blood pressure follow-ups. You see diabetes follow-ups. A lot of acute like injuries, colds, coughs, like a lot of the things in primary care that you generally do see. Um, Lunch for us is around 12:30 to 1:30. At that time, you can either just eat a quick snack or have a little lunch break. Most of my colleagues will use that time not just to eat, but we eat in front of our desks. We'll respond to messages during that time. A lot of times we have lectures built in as well that are all optional. You can kind of turn it on Zoom and listen passively. If you have something that's very interesting, you just pay attention and ask questions and things of that nature. Because it's always learning here at Kaiser and really in any health system. I imagine you're always learning or having some specialist give a talk so that you could always learn from that standpoint. Um, and then the 1:30 to roughly 5 or so is patients in the afternoon. And so kind of same thing. You're seeing patients. For me, right now, I'm not at full schedule yet. So I see about 14 patients a day, sometimes 15. Most of them are in-person visits. You'll have one or two telephone or video appointments. At full capacity, I'll probably be at 20 patients for the whole day. And that's not including like all the inbox stuff that you have. Inbox is kind of interspersed throughout the schedule. Um, yeah, and then I generally leave around 5, anywhere from 5 to 5:30, depending on how busy it is, depending on messages and things of that nature. I have my MSK day is generally Wednesdays, and so meaning my musculoskeletal clinic or sports medicine clinic, where I just act as a referral service. That's on Wednesdays, and so again, my colleagues would just send me things they're not really sure about, or if they need an injection that they don't do, but they want to have done under ultrasound guidance. They'll send them my way. You can see a lot of interesting stuff that way. It's a great way to continue keeping your skills. Um, yeah, that's generally like average day. And then, I mean, I drive about 35 minutes. I live in Folsom, and then drive to Roseville, which can be a little bit of a rough drive on honestly if you hit a lot of lights. So anywhere from like 35 to 40 minutes. I usually get home around like 6:30, walk the dog again, take her to the dog park quite a bit, eat dinner, and then not really a whole lot of time to chill during the weekday, unfortunately. It's like maybe like an hour or two, hour and a half maximum. Just watch TV, chill, just do anything. I mean, right now we're really training our dog right now, so a lot of that is kind of taking place right now. So it's pretty busy, I would say. The weekends are the time that really decompress, and so those are the days that we look forward to. So we'll go to like San Francisco, we'll go to Lake Tahoe. Every weekend, we're trying to do something because if you don't, especially working in healthcare, you're going to burn out. So just take time for yourself. I think that's the big thing.
All right. So, other question would be, why did you decide to do a DO instead of an MD?
Yeah. So, um, I guess so. I chose medicine pretty late, and you know, I won't, I think I'll tell you, I think my GPA was 3.4, I want to say. Like 3.4. I think science GPA was like 3.3 something. And so I don't know what the average is anymore. When I applied, I think the average MD school was maybe 3.6 something. Um, I don't know what the science was, maybe 3.6. The average DO school, I think back then, roughly 10 years ago when I applied, was like 3.4 maybe. And so I kind of fit within that range. And so I didn't actually apply any MD schools. I probably knew that I wouldn't be super competitive for that. And like honestly, med school, whatever one accepts you, honestly. I will kind of caution because DO schools are totally fine. Like I knew I wanted to do primary care, so I knew that wouldn't be a problem. But if you want to do more specialized fields, it might be a problem just because it's you see the squeeze going on right now with especially like Caribbean schools are the first ones kind of being squeezed out. So that's one of the difficult things because there's only so many residency spots, and there's just like DO schools popping up like a ton. There's like so many schools I don't even know anymore that popped up ever since I started applying. So again, the spots, none of our residency spots are not keeping up as much as the number of med schools opening up. And so, again, the residency squeeze is becoming more competitive every year. And so, I think that's one of the big things. If you know for a fact you want to do something super competitive, maybe aim for the MD in the US. But if you know you're going to do primary care, like anything that's like not super competitive, like family medicine, internal medicine, pediatrics for the most part, you're fine. Um, Emergency should be okay. Even anesthesia and general surgery should be okay. But like the real super like specialized like dermatology is gonna be really tough. Orthopedic surgery is gonna be really tough. Um, what other ones? Any of the subspecialties of surgery are gonna be pretty tough. Um, did I say dermatology? Ophthalmology. Ophthalmology would be very tough. Neurosurgery, of course. So yeah, you get the point. It's basically if you know yourself and know what field you want to go into, just know some of the kind of realistic terms there.
Um, Sorry. The other question is, why did you do an MPH?
Yeah, so that came on by accident. I had no idea that I wanted to do an MPH. Um, I think it was part of growing up. So again, my parents own a grocery store, and so I worked in my parents' grocery store growing up, and so I kind of saw a lot of the almost a lot of the similarities between like primary care and like working in a grocery store in a small town where everybody knows you. It's very similar to almost being a primary care in a small town. Like everybody knows you, you kind of know them, you have this really close relationship with your patients. And I thought the MPH I thought it was very interesting because I wanted to learn things from like a population level, how things compared between different countries, between the US and other countries in terms of healthcare, in terms of life expectancy, kind of, overall health metrics. I thought that was super interesting to me. And then how you can implement things from not just the individual patient level, but like a population level as well. Um, I think that was a great year. It was, 1 year as well. It was a 1 year MPH, it's like accelerated MPH. I learned a lot during that year. I met a lot of friends there. And I interned at the Capitol as well at the Department of Healthcare Services. And so I kind of saw how things ran from more of a state level, national level of how, especially with healthcare being so expensive, how it's really different here specifically comparatively to most developed countries who have universal healthcare. I thought that was a very interesting perspective.
What why did you do so you had to do a fellowship to become a sports medicine doctor, right?
Yes.
And how is that process?
Fellowship is pretty much like applying for residency match. The only difference is you just know sooner when you match or not. I thought it was more stressful, to be honest with you. I think because primary care sports medicine, there's less spots. So if you look at general residency spots, especially for like primary care, most residencies will have anywhere from minimum six, maybe per class. Some will have as much as 15 or even 20 at the big universities. So there's more spots in a sense. But for fellowship, specifically primary care sports medicine, maybe one spot, two spots, three spots max. I mean, I think there's one that has 7 spots in Texas, and that's by far the biggest one out of all of the primary care sports medicine fellowships. But most places are going to have maybe two, three maximum. So it's smaller amount of, you have less spots. I remember before I matched, 10 minutes before, I was like freaking out because I was like, wow, I could conceivably fall down to like my 12th spot. And that would have been, in a location I did not want to be in. I mean, at that time I was with my fiance, so obviously I didn't want to move from Chicago, and so I wanted to stay there for one more year at least, and then figure out where we wanted to go. But all intents and purposes, it's the same thing. You're gonna have you have to send in your CV, your letters of recommendation, your test scores for your board scores. Probably missing other things. An application with your essay, similar to residency. So everything's pretty similar there. It's the same kind of idea.
All right. So if you could go back to undergraduate, what would you do differently and what would you do the same?
Oh, differently. I definitely would have been more open to things earlier. First 2 years, I moved with all my high school friends to Davis, and so we're all like from a small town, and so we all decided to live together. So we didn't really like explore that much outside of what we knew. And so I think that's a big mistake. I think that's with anything. Like that's why I really appreciated leaving California to go to med school to totally different state, totally different area that I'd never been to. Same with same with all my training and everything. Going to a city I'd never been to. I think that's always a great way to grow is to get outside your comfort zone. And so I would have gone outside my comfort zone much earlier if I had to redo it. If to do the same, things that I would do the same. Um, Yeah, I mean, I really didn't mind the gap years. I think that actually was beneficial because if I went straight into med school from undergrad, I think there would have been a part of like what if like I think I needed those I took I took 4.5 years between undergrad and med school. And so I actually enjoyed those 4.5, 5 years. I traveled, I worked, and I moved to San Francisco. Um, I just kind of lived like a young adult for a little bit of time. And I think that was, I mean, I don't think I would have changed that because if I went straight, I don't think I would have been as happy in a sense because if once you start on this journey, you have no break. You really don't. And so I think having that in between was really helpful.
You lived with Matt, right, in San Francisco?
No, I lived with him in Davis.
That's right. Yeah.
Yeah.
Yeah. What was it like? You lived with Ravi, Matt, and who else?
No, I never lived with Robbie. Oh, Robbie's back in Fresno, by the way.
Yeah, yeah, I know.
I still need to get in contact with him.
Yeah, he's in Sacramento a lot. Sorry. Um, but I think like everybody that lived at your house became a doctor, right? It was you, Matt.
No, the we had a third roommate, but he was an engineer. I think
Oh,
his name was Brian. He was from Maryland.
well, you lived with an engineer.
No, but all my friends from like the conference, like Anoop, like he's a neurologist right now, resident. He's gonna be a fellow soon. I think he's doing neuromuscular. I think.
I think he's
Uh,
doing neurology something at that stuff.
Robbie's a pediatric ER doc. Derek Ha, he's an anesthesiologist. He's doing his fellowship at UW.
So he's
Um,
up there. Okay.
yeah,
You went to
I
school
don't.
with him, right?
What was that?
You went to med school with him?
No, he went to Kansas City, another DO school.
Yeah, I think everybody like in your group all became doctors.
Not Don. Don didn't.
Don. Oh,
Don Pham.
Don is in pharmaceuticals and he's enjoying life. Yeah, and I think like I don't know. I would say the tip or the words of wisdom is surround yourself with people that um, want to help you be successful and support you.
Yeah, honestly, like all the experiences in college and between the gap years, during the conference, during the pre-surgical conference, I think those are where I met most of my pre-med friends. Honestly, if I didn't join that, I didn't really have any group of like pre-med friends, and so it's nice to be on the same page of people who are kind of aiming for the same thing. Um, and yeah, today they're still my lifelong friends. I always still keep in touch with them, and yeah, same with my med school friends. We'll be friends. You go through like kind of this journey together. It's similar to the conference, Jubin, where working for the conference, you're working year round, and then it really ramps up as um, the conference nears, and then the 2 days of the conference, you're not sleeping. You're just running on fumes. You're just doing everything to make the event like run smoothly. It's kind of like the same thing with med school. You're kind of going through it like constantly getting bombarded and beaten down. And by like all these tests, you have to do 2 to 3 tests a week, and you're always studying, especially with boards. I mean, that was probably, one of the probably the toughest phase of my life. Probably the last like 3 months of second year where you're studying for boards, but you're also studying for your classes, make sure you don't fail and making sure that you're still doing a good job in both. And then, yeah, it almost feels like you're going to war together. And so you make lifelong friends out of it.
So they want to know is what are some good study tips and tricks that you used
As
in
a
undergraduate, med student?
hmm, yeah, don't do what I did. No, in undergrad, like I don't think I really studied the way I should have. Honestly, you learn how to study effectively more as you get older. Um, I think in med school I figured out a better system, but comparatively when I was an undergrad and how much more there is in med school, you have to be just so much more efficient. I thought I was like really inefficient in college, and so I wouldn't take those tips. In med school, you definitely have to be more efficient because you have one test after another, and you have to almost like cram in a sense, but you want to understand things mechanistically. You want to understand how things really work rather than memorizing. And I think a lot of times I fell prey to that to try to memorize it rather than actually truly understand it. And even in clinical practice, if you understand something mechanistically, how a drug works or how a disease process works, then you're not going to forget it. But if you're memorizing it, like, oh yeah, yeah, this antibiotic is for this. But if you understand this is more for gram positive, for gram negative, for um, you know, uh, and name the above, anything that you can think of. If you really understand things from the ground up, you're not going to forget it. It's going to stick much better. So try to learn things from that standpoint rather than kind of just memorizing it.
This person wants to know what experiences would you recommend for undergraduate to ascertain a rigorous medical school path is good fit for yourself.
Sorry, what was that last part, Jimmy?
What they want to know what experiences would you recommend for undergraduates, for the people that want to get into rigorous medical school and see if it's a good
Hmm.
fit for them.
Yeah, yeah. I think any experience that gets you in the clinical realm. So, so I think one of my first ones was I worked as a medical assistant. I think any like medical assisting, scribe, something like that where you're in the clinical realm like 24/7, where every day you're seeing like a patient and learning either passively and trying to like write down as much as you can from what the doctor's saying and kind of you're not going to really understand exactly everything that's going on, but just being in the vicinity of like a physician and seeing how they do their work. And especially why the ER, I think I learned so much in working in the ER as a scribe is even though you're not like understanding, for example, like differentials, and because that's all med school, you really learn all these types of disease processes and things like that. So as an undergrad, you're not gonna a lot of things are gonna fly over your head, but just being in the vicinity of it, I think will first it will increase and heighten your interest in wow, what exactly does this person have. I'm very curious what they're here for, how are we going to treat that, how to get them better. So I think anything that puts you in the clinical realm is great. And I know people always ask like, is there what's the best like activity or best thing to put on my resume? I try to just make it general. Just do something that you think will be good for you, honestly. Don't do it because you're thinking it's going to be good for your application. Just do it because you think I'm going to learn a lot from this activity. Like for the most part, if it's clinical, great. If it's not really as clinically heavy, but maybe kind of attracts you in some other ways, do that. I mean, I think anything from that standpoint should work out.
Um, any other questions, guys? This is your time. I could, call up and ask you many questions anytime. So, um, I mean, I probably would have just asked him like catching up about life and stuff. Um, how do you think technology is changing medicine?
Oh yeah, that's a great question. I mean, even when I was an undergrad, we did like clinical research in the ER and then med school, residency, fellowship. I typed everything. Even I think scribes were still like a when I was when I was applying, scribes was a pretty big thing. And I don't know if they're being filtered out. I think we talked about this yesterday. So Kaiser has already implemented AI to help with note writing, and I think that's huge because most of our job, a lot of it is note writing. So you can imagine. I mean, even in residency and fellowship, sometimes I had to take my notes home. And so I'd see the patient and then, but you got to do your clinical responsibilities there and then take your notes home with you because that's the least important in the sense. You just got to finish them when you have a chance. And I think AI has really changed that landscape. So when I walk into a room, I just turn on my phone, it just records it. It basically summarizes a note too. So it's not just recording it, it's basically summarizing everything in for you. So it summarizes a history and physical for you. It writes out an assessment plan and breaks it down. So if you want to do like hypertension, it breaks down your plan here. Diabetes, it breaks down your plan here. Right knee pain, it breaks down your plan. And it saved a tremendous amount of time. And we're already starting to implement that in like patient responses. So we're seeing, Kaiser's already like toying with ways to have AI respond in the manner that we respond to, which is huge because again, primary care is notorious for having a lot of messaging and patients have easier access to you. That's just the nature of the beast. It's not just a Kaiser problem, that's everywhere. If you look at 20 years ago, I think most of my colleagues only had like 2 or 3 messages a day max. Now you'll have 50 messages in one day. And so the landscape has changed in this regard, and patients have easier access to their provider. And it's healthcare, in a sense, has become a little bit of a kind of you're graded on things, right? Satisfaction scores are huge. So you have to be very nice to your patients, of course. But it's almost become transactional, right? So patients expect something from you and you have to deliver to them or you're going to get a bad review. So that's some of the things that are kind of taking part in healthcare right now. AI is helping to mitigate some of the especially like administrative things you have to do. I mean, it's exciting to see kind of how it helps make our lives easier. Um, and I think many health systems are taking part in that right now. I think it's been very helpful so far.
Um, this is actually a funny one, but how do you deal with difficult patients?
um, you definitely have to vent afterwards. There's just some patients you're not going to be 100% amazing with every single patient. It's just not going to happen. And if it is, you kind of that might be a red flag as well. It's like, are you trying to give your patients everything? Are you, basically like laying over for your patients just to get the A score? Um, but I think in many ways you have to the one of the best ways to mitigate difficult patients is to just be honest with them. Sometimes you have to set expectations. So a lot of patients have almost like skewed expectations and they don't understand some of the nuances of where you're coming from. So a lot of times explaining is probably the best way to do it. And explaining in a way they understand is what I've found to be the easiest way to diffuse most situations. Because if you're short with your patient, if you're like stuck, if you know that what they're saying is wrong and you're kind of shutting them down, that's never going to be that's never going to elicit a positive reaction from patients. It'll make it even a worse encounter. And so I think kind of the biggest thing, and that's just not just in medicine, that's just everywhere in general, right? If you're if you come from a standpoint that you're understanding where your patients are coming from and explaining things in a way that maybe they're not aware of, or answering the questions that they were coming from this angle because they just didn't understand it, they'll appreciate it much more, and you'll see that as well. So a lot of it is really come down to communication and knowing what your parents patients are coming from and trying to really explain things that probably they're missing.
This is they want to know how has your MPH impacted your patient care?
Um, I thought I'd use it more at this point. I think as I get older, I think I'll use my MPH a little bit more. I think right in early in my career, like right now, I think I'm very much into you know, improving my clinical skills because I mean, 6 months in, I'm still asking a lot of questions, right? I'm using a lot of resources, making sure you're kind of like doubting yourself. You're like, wait, is that the right thing? Do I need to look things up? I feel right now, maybe not so much. But I feel as my career progresses, I think the natural progression, once you're settled in your career, is to find new challenges. And so I think as I get older in my career, I'm more settled in. Uh, I might get that itch to kind of explore some of those options from a not just an individual level with patients but more of having a trickle down effect from the top down. I think seeing things from a population standpoint, how can I address my entire population, my community around me, not just the individual patients I see. And so to answer the question right now, probably not a whole lot, but I think in the future, I hope to. Yeah.
Um, how do you deal with preventing burnout? Well, you haven't, I mean, this is coasting you because residency was much tougher than now, right?
It's different in different ways, I think. I think residency is, I guess that it's going to be tough going in, that you'll have some rotations you just don't like. I mean, in residency, I didn't like OB. I knew I didn't want to do OB at all. I didn't like now. I don't really do women's health. So it's, I mean, any job you can kind of decide what you want to do, what you don't want to do. I didn't like surgery at all. So there were some rotations where you just knew like, it's gonna be like a rough month. Like ICU, we had to do a couple months of ICU. The second year of ICU was rough because we had to take 28-hour call every 3 days, and so that was rough. So like you knew certain months would suck and your schedule would be terrible. Here it's more consistent. You get to lay out your schedule Monday to Friday, coincides with like your friends, your family, because they're gonna have the weekends off. So that's a big thing too. And I think that's a big thing to kind of touch on, like specialties as well. Like for example, and I'm gonna kind of go off topic. I was interested in ER. I thought ER was like a really exciting. I really like to see a little bit of everything. I like the fast-paced nature. But what did it in? Why I didn't apply ER at all? It's because I couldn't do shift work. I was like, I can't do night shifts. I don't want to do night shifts. I don't want to be working 2 a.m. when, and I'll have a random like Tuesday or Thursday off when my family and friends have to work, and then have to work the weekend when they're off. So it's like little things like that. In terms of specialties, kind of knowing what you don't want to do is to me more important than knowing what you want to do because it does take time to arrive to your specialty. And knowing the bread and butter, if you can't do the bread and butter of each field, then you probably won't survive in the field very long, and that leads to even sooner burnout. So yeah, try to kind of get that balance.
Brother, I know you too well, and I've worked in ER for a long time. You're too mellow for ER.
ER docs are mellow.
No, they're not. Are you kidding me? They're like bunch of they're adrenal junkie, and I don't know. I just think you're too mellow. Um, how did you define grit as you went through bachelor's and DO school? What personal growth did you see in yourself, and what things you wish you did prior?
Sorry, you kind of broke up there.
Oh, did how did you define grit as you went through your undergrad and med school?
Oh
And
yeah,
what personal growth did you see in yourself? And if
yeah.
you could change anything about it.
um, yeah, I kind of grew up with the kind of like the I don't know what you want to call it, kind of like almost like an athlete mentality. It's like suck it up, just work through it, that type of thing. Same with, throughout college, throughout med school. Um, you're just put your best foot forward, just put your head down, just work hard. Um, as I've gotten older, especially in like residency and fellowship, that can also almost mean or be perceived as almost like selfish desires, right? So your own personal goals, you're kind of like uh, a little bit tunnel vision in many ways, and so I think it works to an extent if you're very, driven by one thing, which I was for an extended period of time. I don't think anything else really mattered besides the goal of getting into med school for like several years. And then same thing with residency. I wanted to learn as much as I could. But it comes at a price, right? In many ways. You want to be as well-rounded as you can as well. You want to be open to other things, not, and sometimes it's hard to take a break, for example. Like your life can't just be all medicine in many ways. You want to get a good balance from other life experiences to really, you know, kind of give you a different perspective on things. And so I learned that progressively in my medical career to kind of take your foot off the gas pedal at times. Like, for example, right now, even though I'm still, I'm very much very young in my career. Um, I've taken my gas off. When I go home, I really don't look at anything medicine. I really don't want to talk about medicine either. It's a healthy thing to just unwind and really just do things that are totally different. Like, I don't know, if you want to talk politics, if you want to, talk about TV shows or whatever, movies, really exploring the other side of life that it has to offer. Because again, taking those breaks, those necessary breaks, and de-stressing and just forgetting about medicine almost actually is actually very beneficial too. So it makes you come back harder, stronger, gives you that necessary break, that time to unwind, and it almost makes you a better person from that standpoint too. I don't know if I answered that question though.
What would you do differently
In my medical career,
in your undergrad or med school or
um,
residency?
anything different? No, I mean, I think I was very happy with where I ended up, or excuse me, with clinical rotations. I mean, I learned a lot from each rotation, but again, I really knew what I didn't want to do, and kind of I was narrowing it down what I wanted to do. Um, and in residency, I think I made the best out of that. Those 3 years. Um, it really opened my eyes to also musculoskeletal, which I never thought I would go into. And then going into fellowship, really fun year. I really enjoyed that. Yeah, I don't think there's really a whole lot of regrets there, honestly. So, I have some friends who regretted like, oh, I should have went like MD versus DO. Like some people will say that, especially if you want to like really specialize, then yes, I think that could be a difficult thing to accept. But if you kind of know what path you want to take, then I don't know if it makes that big of a deal.
They want to know, in retrospect, are the medical student loans worth it when you look at your starting salary as a doctor? I don't know, man. You make pretty good money.
I mean, it depends. Um,
So it's all relative. I mean, I think if you're comparing it to a tech billionaire, no, it's not. But
yeah, I mean, as physicians, you'll be well
I think
compensated.
you
You'll
froze
live
up. Can you
comfortably.
repeat that? You froze.
Oh, as physicians, you'll make good money, no matter what specialty you are. Um, you'll be comfortable for the most part. Will you be rich? I mean, define rich, right? I mean, maybe if you're a neurosurgeon, if you make a million or over a million a year, um, or if you do if you're a dermatologist, you just see a ton of patients and just do a ton of procedures. Yeah, you could probably crack a million. Um, in terms of delayed gratification, because yeah, you're in school for a long time, and so you're not really realistically making money until your 30s, honestly. And so yeah, that definitely the loans rack up, the interest rates rack up, I know COVID put a freeze on that for me and most of my colleagues at that time, which was great. I don't know if that will happen again. Probably not unless there's another global pandemic going to take place soon. But for the most part, again, you'll make it back. It's the extent and the first couple of years of practice, you still have to grind. I mean, I'm grinding the first couple of years, like living in an apartment, making sure I, you know, pay back loans and accrue enough money, that type of thing to potentially buy a house. So you're still living frugally. Like me and my wife still share one car. We don't have two cars. And so we are living pretty frugally right now.
But
And
your wife also works from home, right?
mhm, yeah. And so yeah, my wife works from home, but it'd be nice for her to have a car too, right? I don't think anybody would want to be stuck at home for like like depending on her husband to, come home with a car so she can actually go somewhere. I mean, that could take a lot of hit on your mental health there. But I think for the
Well,
most
you did marry out of your league, so I'm just saying that.
part, not lying there.
Huh?
Not lying there.
Anyways, yeah, I mean, like, I don't know. I think the problem is that I think society now looks at, I don't know, like, we all grew up poor, and so for us, like, being able to have a job that's in the mid six figures, it's pretty good. Like, you know, I mean, I don't know. Like, I'm pretty sure your parents work, 18, 20-hour days at a grocery store and then make what you make now. So,
Yeah.
and medical school debt is an investment. So, I mean,
Mhm.
your parents had to go buy, I mean, I'm just using you as an example. They had to start like capital to go buy a store, and
Yeah,
so you basically had to go put capital down to get your degree because you can't practice medicine without a degree.
yeah,
And so, I mean, it's all relative, but and this is something that I guarantee you, your parents worked a lot harder than you do today.
for sure. I mean, my parents own a grocery store. They took 5 days off a year, and so they literally worked 360 days a year. Like, I mean, growing up to that, seeing them work like that, it's all perspective, right? It's like what I
And you could, yeah, and I'm telling you, you're probably making what, twice as much as they make now, and you work what, 50 hours?
yeah. So it's nothing to complain about, right? In relative terms, like I saw what they did, and like I was like, no thanks. I don't really want to go that out. And so what I'm doing, yeah, it could be, days are really like you're working hard. Like you are definitely working hard. But when I go home, I decompress. I don't think about medicine. Again, 5 days a week. I mean, here and there I'll work a random half day Saturday. Like tomorrow, I'm working a half day Saturday, but for the most part, it's pretty manageable. You still have time off. Your structured day schedule is there. So I know I'm Monday to Friday, I'm working hard. Saturday, Sunday, for the most part, I could, do whatever and just take my mind off things.
Yeah, I remember like even like when we went to Costco to buy stuff for the conference, you're like, man, my parents, we used to do that all the time, right? I remember you mentioned that a couple of times. And yeah, I mean, I could tell you that your parents probably work a lot harder than you do right now. So, and they didn't make as much as you do now. Um, so I think it's all relative. I mean, it is hard, it's not easy, but
Mhm.
it's a choice that you have to want to make. So,
Yeah,
um,
honestly, yeah, once you're done from it, I mean, again, I think at the beginning stages, I don't know if most people would agree with me there. I think at the beginning stages of med school were probably the roughest. The first 2 years, easily the roughest, I thought. Especially the second year of med school was the roughest. But once I got past that, once I got more clinical, it became much better. I like third year. I like fourth year. I enjoyed residency, even though it was hard as well. But it's all clinical, so that's what I went to med school for. I wanted to be a clinician. And so anytime I'm patient facing, it gives me, that motivation and it makes things stick more when you see a patient presenting with something. rather than reading it from a textbook, which I always had trouble from that standpoint in med school, like reading something off a slide and being tested on it. That was always tougher for me. But when I saw it in person and had to present it to my attending and give a plan, I felt it was much more natural. Like it made more sense that way.
Um, yeah, and I think like I mean and like to be honest, like you probably right now is probably the most that you're gonna work, right? Right now is probably the beginning of your career is probably the most challenging, but as you go
Yeah.
on, your pay increases and you become more efficient and you get
Mm-hmm.
seniority and you work less. So, um, yeah,
Yeah.
I think it's an investment you make in yourself, and I think you know, just like anything else, it's the student loans don't look at it as some sort of it's basically it's capital investment. It's buy a house, you buy a business, you start a business. It's all relative. And so,
Yeah.
and I think if you want to go to medicine, there's a lot of reasons not to do it, but I think like fear of the loans shouldn't be one of them. Like you're going to be okay.
And there's still like public loan forgiveness too. A lot of my friends are like entertaining that option as well. If I mean I've had friends who are like 300, 400,000 in debt. I mean that's a ton, right? Um, I don't know if I would pay that all back, honestly. I'd probably go the public loan forgiveness route as well. So there are programs like that to help where you just pay the minimum every month, and then if you work X amount of years, they'll pay it all off for you. So those options are there as well. So I would say don't let it dominate everything, especially with like choosing a specialty as well. Don't choose something just more so for the pay, especially if you're so scared of loans, if you're not gonna enjoy it. Like, everyone wants to be like probably a dermatologist for the most part or ophthalmologist. I mean, I don't know if the road to happiness is still kind of rings true, but don't choose it just based off money. Let's say if you went through a rotation and you're like, yeah, maybe I could see myself doing it, but I really love the money. Try not to look at it from that standpoint because you're in it for the long haul here. If, for this career, 20 to 30 years or longer, you want to do something that you love. So look at it from that perspective. It'll all play out. You'll make enough money. Just follow your heart in the sense of the bread and butter of each specialty, what you want to do. If you can stomach that, then definitely pursue that option.
This is kind of the same line of questioning. What was the most difficult time while practicing medicines? Did it involve working with other medical professionals or patients? And how did you overcome the challenge?
Um, Probably med school. So third year clinicals. I think I worked with general surgeon. Um, Super dedicated guy. I remember he was in his mid 70s, still working like 110 hours a week. The guy just I remember I asked him, I was like, his name is Dr. Lang. I was like, hey, Dr. Lang, how do you like um balance have work-life balance? Because I always saw him like just work. He always told me like, yeah, I work about 110 hours, not as bad as I used to. I was like, 100 hours a week. I was like, that's pretty rough. And he's in his mid 70s, right? And so I asked him, I was like, hey, yeah, how do you have that work life balance? And he said, Alvin, I'm divorced. And I was like, wow, that kind of like framed it all for me right there. He was literally dedicated his life to working as a surgeon. And I think he could tell like that I just wasn't really, I was in the OR. I just really wasn't, I didn't feel natural at all to me. I felt that whole experience of being in the general surgery rotation. It's just I knew I didn't want to be a surgeon like from the beginning. I tried my best to try to work every rotation. You're going to work hard. I tried my best to make it seem like I was motivated and dedicated to it, but I just couldn't. I just really just didn't vibe with him very well at all, and I think he could see that. And so that month was pretty rough. So you'll have that, in certain rotations. I've had friends have this same exact thought where they hated the rotation, or they had someone that they just did not vibe with. That's probably going to happen probably maybe one time in your career at least, where you just don't vibe with somebody, or the rotation, or the co-residents that you have on there. Something is just not right. It just doesn't. You just don't enjoy being there. It's probably making you miserable. I mean, luckily it's only a month. It was only a month, but I think it makes you stronger from the standpoint that you have to build tough skin in medicine. I think it still rings true, even though the culture has definitely gotten better from comparatively what it was like 20, 30, 40 years ago. But there is still that rite of passage in many ways that is still rings true in medicine, where each rotation is known. When you're on surgery, when you're on OB, or you have to be on call as a med student, or you have to work like almost like mirror those long hours to see what it's truly like in that specialty. And I don't think that's wrong, because yes, you definitely need to know going into when you're choosing a specialty, you really need to know the ins and outs of it for the most part. And if you're getting a inaccurate view, then you're almost like doing yourself a disservice, or the rotation service, or your med school or residency is doing a disservice from that standpoint. Um, so yeah, I don't know if I answered the question, but I think, yeah.
Yeah, I mean, you're gonna be I think it's just anything in life. You're gonna run into people that are really kind and really great, and you're gonna run into people that are jerks, and that's just like life, you know?
Hmm.
You just have to, and that's with any job. I mean, but I also think that if, once you go up in the, at least with like medicine and healthcare, it's really regulated. And I will tell you this right now, if you watch TV shows and those types of things, those are not real because some of the stuff, I mean, I tell you, if any of the doctors I work with do that stuff, they would literally be walked out. Like, this is not like, you don't throw tantrums, you don't do any of that stuff. You don't belittle people, like, you know, but
Yeah.
you're going to work with people that are difficult, and that's just like any other job. So,
Hmm.
your personal and coping skills, and, and with patients, you're going to have to take patients of that you're not. I mean, last weekend, I had to take care of this patient who had SS and swastikas all over himself, and I was just like, you're gonna have to do it. It's uncomfortable, but
Hmm.
they deserve the same respect and dignity that anybody else does, and so
Hmm. Yeah.
I mean, I remember during COVID, I had some patients like, oh, I don't want any Asian doctors, and it's like, well, good luck, you know. I
Not in
mean,
the.
and you're gonna get that, and you're gonna have people that are gonna be around you that support you, and there's gonna be racist, and so yeah, and yeah, but I think it's any job is difficult. I mean, at least in healthcare, we have a lot of protections.
Hmm.
Like in the ER, like if a patient strikes me, it's actually a felony. Doesn't matter if it doesn't hurt me, but technically we could charge them. In California, it's a felony, so um, it's not a misdemeanor outside. So once they're inside the hospital, you're a frontline health worker. But also, like, you also have to understand that you're dealing with people at their worst conditions. But at least you have a lot of like resources and systems that support you versus working at a fast food place or any other most of the other jobs. So
Hmm.
I mean, so what is the most difficult injury or condition you ever treated?
Ooh.
That'd be COVID. We don't know what we're doing.
Oh man, has to be residency. Trying to see one. Oh, I mean, the one that might probably had the most lasting impact was, of course, it was my last shift in the ICU as a second year. So as a second year resident, we were basically the senior resident. So we had to do the 28-hour call every 3 days. And interspersed between there, you had to do regular 12-hour shifts too. And so a very tiring month. It was my last call. We had to do like 8 or 9 calls that month of 28 hours, just no sleep at all. And I remember one patient came in and he had like a GI bleed and totally came in like conversing, very friendly. We thought about actually, downgrading him to the floor because he's stable for the most part. But that night, of course, like at 1 a.m. or so, he had a big bloody bowel movement, and that kind of set things down where he was basically losing blood pretty quickly, and he ultimately passed away around like 6 a.m. right at the start of the shift change. And throughout the night, I've been calling specialist after specialist, interventional radiology, gastroenterology, general surgery. We couldn't figure out where he was bleeding from. We had a couple of CT scans. He was too unstable to do like a colonoscopy. Um, Interventional radiology even had to go in and burn some vessels that potentially were the most common causes of bleeding in the hopes that they would stop it and cauterized it, but he still was bleeding, so they weren't going to go in and just randomly cauterize everything. And so that was like almost a helpless situation because I knew he was declining and there was nothing we could do because we didn't know where he was bleeding from. And so, that morning it was rough. It was basically like it felt like he died on my watch because you're there, you're the senior resident, and then he declines over time over the span of 5 6 hours. And so that had a pretty big effect on me. I think one of those things I remember I talked to everybody the day after the day or the following day when I couldn't go home. I had to just talk to like my program director. I had to talk to co-residents. Had to get it off my chest because that stays with you. It's almost like the first real death that feels like you was under your watch. And so that was always has a lasting kind of image in my mind. And the fact that we had to talk to his family, that was probably the toughest thing because they're saying, we just saw him yesterday. He was like in good spirits. What happened? I think having that discussion was really tough. And just seeing death in general, especially when you feel like you're responsible for it, was probably one of the toughest things.
They want to know, how did you study for the MCAT? What tips do you have or recommend? Do you still remember?
I don't even know how I studied for the MCAT. I think I used Kaplan. Oh yeah, I think it was the Kaplan you provided you then. Yeah, I used Kaplan. I didn't think I used the actual in-person course. I don't think I did. I don't think I had time for it. I just did practice tests. Just do practice tests. I mean, that's the best way to do it to me. Practice tests, put yourself in that situation, see what you know, what you don't know, and then learn from those practice tests. Same for honestly any of the board tests that you're going to take throughout your medical career. Just practice tests, practice questions. That's really the best way to learn.
This is, if you could travel any place in the world, where would you go?
Uh, Man, I would probably right now. So me and my wife are we really enjoy traveling. We try to do one international trip a year. This year we'll go to I'm going to go to Taiwan in September, where my wife is from, and then we'll go to French Riviera right after in France, southern France. I really want to. I haven't gone to London yet. I really want to go. I've been wanting to go there for years.
Where are you going to go, to southern France, you said?
Yeah, southern France,
Where?
French Riviera.
Let me know, dude. Uh I got family down there.
Oh, yeah, it's my friend's wedding. He's having a wedding down there. It's gonna.
Where? Do you know exactly where?
Uh, I don't know exactly. I
Text
could.
me later. Um, so what do you like about Kaiser healthcare system, and why did you choose to work there?
I always thought I had an inkling I would come back to Kaiser. I was a Kaiser patient when I lived in South San Francisco like 10 years ago. I like the model. U.S. healthcare system is I mean broken for a lack of better term. It's a lot of fee for service. So I kind of I saw this in fellowship where in the U.S. healthcare system for the most part, It's fee for service. So the more you do, the more procedures you do, the more you get paid. And so, in fellowship, especially with primary care sports medicine, I had a lot of my attendings just injection machines. Like literally, some people would see 30 to 50 a day, and like 80% of them would be injections. And they would tell me they'd make, 700K, something like that, like some crazy number. And I mean, I remember a patient came in with ankle pain, foot pain, and he said he got an injection and he wants another injection. And I was like, for what? And he's like, for bad arthritis. And then I looked at his x-ray. There was no arthritis there. And so after more a thorough exam, I was like, you have neuropathy, peripheral neuropathy from your diabetes. And this doesn't warrant an injection. It's the fact that another provider gave him an injection because it's quicker. If you have to explain the pros and cons of it and say, hey, have a discussion, it takes longer. But it's easier just to say, hey, let's just do an injection real quick, that type of thing. I think that kind of jaded me in terms of what type of system I wanted to work in, especially with the MPH. I think that really kind of opened my eyes to other healthcare systems, especially in the world, which is, um, for the most part, government owned and universal in the sense that here it's completely opposite. And I think Kaiser tries to recreate some of the managed care that is prevalent in most developed countries. So the emphasis is really on prevention, which I think all healthcare should be. Emphasis on healthcare or on prevention. I mean, I'd say 80% of things we see from a chronic disease standpoint is all from prevention. It's diet, exercise, body, mind, spirit, right? So you really want to attack things from a natural standpoint if you can, rather than going straight and resorting to meds. And so I think that resonated with me a lot, with the Kaiser model, with the PCP being really the quarterback here, that you can't even get a referral unless the PCP sees you. And, other health systems, I'll put in a referral for dermatology, I'll put a referral for all these guys because they'll never turn down a referral for the most part because it's money for them. Anytime you see a patient from a referral standpoint, they make money from it. But the Kaiser model is not like that. It's, do you truly need dermatology, or can I take care of this? Do you truly need gastroenterology? Can I take care of this on my own? Cardiology, can I take care of this on my own? If I need help in regards to management for something that truly requires a cardiologist kind of oversight, then yes, I think that's warranted. But to go like straight knee-jerk reaction to just getting them on board with specialists, I just I just didn't make any sense to me, from like a fee-for-service model.
Very cool. Well, it's 6:31, and if you don't get home, your wife's gonna kill me, so I'm gonna let you go. Thank you again for coming today, and great seeing you, man. I'm sure that we will have you come again every week,
Thanks for having me.
and tell Kaiser to fix the Zoom, I guess you could say. But thank you again for coming, and yeah, and it was great seeing you, man.
Yeah, shoot me any questions if you have. If anybody has any other lingering questions, more than happy to answer them.